Thank you, Dr. Bueno, Dr. Matar, and the SAGES organization for allowing me to give this talk. I have no disclosures. So we've heard these last two talks talk about best practice elements and how they improve patient outcomes, as well as ongoing critical analysis of our outcomes, which is essential to improving these elements. But currently in the United States, patients receive only about 55% of recommended care elements. So why? And it's a complicated answer, but there's one aspect of it called reliability that I think we as surgeons can affect change with, and that's what I want to talk about. So Patrick and his group did this great study looking at feasibility and impact of an evidence-based program for gastric bypass surgery. Their first aim was to investigate whether an integrated health care delivery system could successfully implement a multidisciplinary evidence-based program for gastric bypass surgery. And their second aim was to evaluate the impact of the evidence-based program on clinical outcomes. Their core principles for this was to create a culture that expects and insists on elimination of unwarranted variation as a patient safety issue, to clearly describe organizational outcome goals and set process expectations at a minimum of greater than 90% level reliability, which we'll get into. Ensure that variation in protocols are driven by patients rather than individual providers. Require clinicians to communicate and document exceptions, and to provide resources to measure the outcomes and reasons for noncompliance. So how do they do this? They got stakeholders from bariatric surgery, bariatric medicine, and the administration to meet and create these guidelines, using the literature, using guidelines from ASMBS and SAGES, as well as the Betsy Lehman Center. The clinical specialists were enlisted to aid in the development of the guidelines that incorporated 34 best practice elements for the care of bariatric patients undergoing primary gastric bypass. The working group was supported by clinical effectiveness specialists, statisticians, and IT specialists who actually created EMR workflows to facilitate compliance and reporting. And best practice elements were designed to be actionable and measurable. They divided their study groups based on reliability. And reliability is the percent of each study group that received 100% of the best practice elements. So group alpha was the year before implementation of the program, so the control group. Group beta was the first year of implementation, and you can see it's about a 40% reliability. But group omega was the second to fourth year of implementation, which had a greater than 90% reliability. So they looked at their outcomes. And for length of stay and readmissions within 30 days, both intervention groups had a significantly decreased rate compared to controls. However, extended length of stay, ICU admission, major complications, and any complication was only significantly decreased in the high reliability group compared to control. So they looked at the impact of reliability, and specifically its effectiveness, by doing a logistic regression, adjusting for age, sex, BMI, comorbidity count, a medication count, surgical approach, and they found a significant decrease in the odds of extended length of stay and post-op complications in the reliable group, not the unreliable one. Looking at the efficacy of of reliability, they actually combined both the unreliable and the reliable group, and they actually reanalyzed this based on the percent of best practice elements that were completed. So they did a logistic regression, and what they found was that for each 5% increase in percent completed best practice elements, there was a 1.74 times decrease in extended length of stay and 1.44 times decrease in postoperative complications. So as you increase your reliability or reliable delivery of care, it has a direct impact on these outcomes. So it's an independent predictor. So we have evidence that reliability works, but how do we improve that 55% of delivery? Not all of us have this Geisinger health system support, which is where this study was done. But the principles are scalable. And one of the key aspects to reliability, I think, is multidisciplinary commitment to care, which in and of itself is predicated on engaging all your stakeholders. And what I want to show you is how we've done it at OSU. So this is our multidisciplinary care program, as all programs are. A lot of stakeholders involved, and we have standardized protocols for everything. In terms of what we have done, we started our quarterly quality meetings that we actually codified in 2014. Before that, it was just surgeons talking to the various nurses or program coordinators as needed. We invite everybody to these meetings, including surgeons, NPs, our nursing managers and staff, both in the clinic and the hospital, social workers, residents, medical students, clinic administrative staff, hospital quality and operations staff, and our quality coordinator. We review our defined metrics and make recommendations for improvement or areas to investigate. Our metrics, we have 3 major procedures that we do. The metrics that we examine are length of stay, readmissions, reoperations, superficial and deep surgical site infections, bleeds requiring transfusion, and mortality. And the metrics are defined by looking at improvements over time with an eye to keeping the MBSA-QIP national averages in mind. So this was the results of our first integrated meeting. You can see there's a lot of red under the quarter 1 of year 14 compared to the goal. So first thing was we identified areas of improvement, looking at length of stay and readmission rates. At this point, as the surgeons at the table, my advice is be quiet. Just listen to the stakeholders and keep asking why until no one has an answer, and then together formulate an intervention. So really, we were asking why. My floor nurses were telling me that there was prolonged nasal prong use. There was incentive spirometers were still in their package on the other side of the room. Patients were just not getting up out of bed by noon the next day. And one of my clinic nurses informed me that, in fact, patients were calling constantly after they were being discharged because they were confused about how to drink. So after asking why enough, we all agreed that there was variability in specific bariatric-related knowledge and experience among the nursing and house staff. So we sought to fix it. We created a bariatric care coaching program and implemented it on July 1st of 2014. It consisted of 4 charge nurses with a bariatric nurse certification who were identified as having an interest in bariatric patients and volunteered to assume this role. On the day of their assignment as charge nurse, they were also the care coach for the bariatric patients, and their role was to educate the patient and the families on the daily plan of care from the time the patient arrived from the PACU to the time that they were discharged, to participate in daily rounds with the surgical team, and to follow up with patients via phone calls once they were discharged, not only on post-op day 1, but post-op day 4 and 7 before they actually saw us in clinic on 14. Education that was delivered included discussing the plan for IV and PO pain and nausea control, including the doses and times of the medications, explaining the importance of weaning off oxygen and how to use the incentive spirometer, encouraging ambulation, talking about discharge, even the day the patient arrived on the floor, and everyone was given a bariatric package, which included the written explanation of what the nurses were going to tell, what the nurses were teaching them, a protein shaker, pill crusher, 1-ounce medicine cups, and an abdominal binder. The nurses created a standardized flow sheet because we knew to improve the consistency of care among the different providers, there had to be standardization in terms of delivery and documentation of the best practice elements that we wanted. So this was the flow sheet that they created, touching on pain control, oxygenation, SCDs, diet, nausea, activity, goal for that day, goal for the following day, and any barriers to success. So after a year after its implementation, we studied it, and we had about 261 care coached patients and 264 controls. We found that there was less intractable nausea and vomiting in our care coached group. There was a shorter length of stay in the care coach group, which actually translated through the sleeve patients, not through the gastric bypass patients. Unfortunately, there was no effect on readmission rates. But looking at the HCAP scores, there was an improved nursing communication regarding medications, nursing communication regarding discharge information, as well as likelihood of recommending the hospital. So, this didn't have the effect I wanted, but it had an effect. And the only reason this worked was because the key players, being the nurses, were allowed to drive the bus. They're the ones who created the programs, created how they wanted to teach the patients, how they wanted to communicate between themselves and amongst nurses in the clinic, as well as how they wanted to document. And another sort of bonus that came out of this was the fact that because this was theirs that they created and were growing and were supported with, they wanted to continue to improve it. So, going back, this is where we started, that 14.2%. We implemented the care coaching program. We studied the care coaching program. We still have a really bad readmission rate. Why? So what the nurses decided to do was analyze the following 6 months of readmissions. So we did a root cause analysis for the readmissions using the care coaching notes specifically. There are multiple reasons why patients can get readmitted, but they wanted to improve this program. And we found, again, 8.3% readmission rate, but looking at only the readmitted patients, the length of stay was about 3.17 days. The time to readmission was 11.5 days. The reasons included nausea, vomiting, dehydration, wound infections, and you can see here, interestingly, we found that the patients that had wound infections came back earlier, and pain. Pain, 50% of the time was associated with nausea, vomiting, and dehydration, 25% of the time with superficial infections, 17% of the time with a deep infection, and one patient had an SMV thrombosis. So what did we institute? Looking at this and drilling down, what did we institute? Looking at nausea, vomiting, and dehydration. When you drill down, it turned out that 50% of the patients that got readmitted actually were struggling in the perioperative period. So we modified our order sets to include other anti-nausea medications as a default, not as an option. We also found that 88% failed to meet their targets at home. So we defined concrete fluid targets with an action plan for when the nurses called the patients. So if they were severely under target, we'd give them until the end of the day of that call to see how they were doing, and if there was a problem, bring them into clinic that day or the following day. And if they were moderately under target, we would reinforce the importance of oral intake with further patient education and follow them up again with a subsequent phone call, and if they still were dehydrated, bring them into clinic. With respect to the wound infections, based on the fact that we found that they were actually admitted earlier than the typical patient, we realized we probably weren't asking the right questions. The question that we were asking on our telephone conversation was, do you feel pain or discomfort at the surgical site? Probably not specific enough. So we added these. What incision hurts? Where is it located on your abdomen? Is it tender? Is it warm? Is it red? Is the redness spreading? Push on that area. Does it turn white and then turn red again? Like really basic questions that would help us help our patients. So this is what our flow sheet looks like. It's embedded in the EMR, so both our nurses in the hospital as well as in the clinic can communicate with each other. So that was that initiative, and that's the change that happened. We are now in the process of investigating the outcomes. Another sort of multidisciplinary approach to this example is surgical site infections. You can see this abysmal rate in 2015, about 8.7%. And I distinctly remember at that quality meeting, one of my PGY1 residents had mentioned that they'd seen an oncologist use a really small wound protector to extract some specimen. And given that most of these infections are at our 15mm port site, we decided to use it. I would have never even thought about it had that person not been at the table. And so we implemented it there, and so now you can see the trend towards improvement, and so that's something we're studying as well. In July of 2017, we implemented the energy program, which required buy-in from not only our clinic nurses, but our perioperative nurses, our floor nurses, the anesthesiologists, as well as the residents. And so we are almost 1 year into it, and we'll be studying that. So I hope what I've impressed upon you is that reliable delivery of care is critical for patients. And how do we approach improving reliability? Teamwork, feedback, and training through regular meetings, review of deviations from best practices by medical and surgical teams in discussion with administration, creating opportunities to modify both methods of data collection and the specific operational definitions of best practice, and regular meetings of medical and surgical bariatric teams to address specific failures, create the opportunity to educate and modify behaviors. This is our program. I would say that now this is who is involved in taking care of our patients, and this circle will continue to expand because this is a multidisciplinary problem. Reliability depends on this multidisciplinary commitment, which in turn depends on engagement. So really a central tenet for reliability is engagement. So it's very straightforward. Bring everybody to the table, define your metrics, create processes to address these metrics, implement the processes, and then analyze the impact. Thank you.